Good evening, everyone. So, today I'd be discussing a slightly duller topic, that is hyponatremia. But we all know that it's a very important topic. I think many of us would have faced situations where you want the sodium to rise in a particular way, and in spite of you following the guidelines, it does not happen the way you want it to. So, that's exactly why I thought we'll discuss this today. That is some practical bedside tips in managing hyponatremia. So we'll start with the case scenario and we'll see what are the questions that come in our mind, and then we'll see what the guideline says and how to practically manage them. So coming to the topic, that is practical tips in management of hyponatremia. So this is a child 2-month old, 2.5 kg baby with diarrhea with one episode of seizure. And on examination, the child is having features of dehydration with our investigations showing a sodium of 117 and potassium of 2.5. Now, what are the concerns when you're looking at this child? Your concerns are one, definitely the child is having seizure. Should I give 3% saline? The next is the child is having dehydration. Don't I need to correct it? If yes, then which fluid should I use? Now, should I calculate a deficit over 48 hours or should I calculate a deficit over 72 hours? Should I go for acute correction because there seems to be a diarrhea, so it might have been a rapid fall in sodium? Now, what about hypokalemia? So, just see a simple case of a 2-month old with hyponatremia. You have so many questions to be asked. Now, before we really discuss how to manage this child, let us see a few basic concepts regarding hyponatremia. So, what is hyponatremia? We all know sodium less than 135 is hyponatremia. What causes hyponatremia? If you want to know in simple terms, it just means that hyponatremia is either because you have lost sodium or because you have gained water. So now we need to understand a basic concept, that is, two-thirds of your fluid is in the intracellular compartment. Only one-third is there in the extracellular fluid, maybe 6% or so in the as the blood volume. So when we talk about hyponatremia, we are basically telling that serum sodium is low. We also need to understand that sodium and water are friends. So wherever sodium is there, water will be there. So if sodium is low, the water in that compartment will be low. So if you have hyponatremia, what will happen? Remember, the water can always freely move between the extracellular fluid and the intracellular fluid. If the sodium levels in the extracellular fluid comes down, what will it do? The water from the extracellular fluid will move towards the intracellular fluid, causing swelling up of the cells. And which organ are we most bothered about by this phenomenon of shifting of water from the extracellular compartment to the intracellular compartment? Definitely brain. So hyponatremia leads on to brain edema, which is clinically manifest as nausea, vomiting, headache, confusion, drowsiness, seizures, even coma and death. So hyponatremia is extremely important. Now we need to know that between 130 to 134 it is mild hyponatremia, 125 to 130 it is moderate, and less than 125 is severe. Most of the symptomatic hyponatremia, the sodium will be less than 125. In mild and moderate hyponatremia, there is no emergency. Just investigate, find the cause, and treat the cause. Whereas when it is severe hyponatremia, you need to immediately treat, especially if it is symptomatic. So the first step whenever you have a child with hyponatremia is to get a proper history and examination. In the history, you want to know about fluid intake and fluid loss. That would include all normal and abnormal losses. That means what did the child take? Did the child receive any IV fluid? If yes, what was the IV fluid received? Is the child having a loss in the form of diarrhea, vomiting, or a polyuria? So you need to know all of that. You also need to know a clinical assessment of hydration. That's very, very important in management of hyponatremia and ultimately the neurological status of the child. The next step is definitely sending investigations. The basic investigation is send for a paired serum and urine osmolality, send for urine sodium, check a blood glucose to see you are not dealing with hyperglycemia. And if the child is sick, like our child, 2.5 kg, having a seizure, or child with a failure to thrive, you find something abnormal in the baby, definitely do a blood gas analysis also. So these are the only 4 basic investigations we want initially to manage a child with hyponatremia. Now, the first step is to identify, is it a true hyponatremia? That is the reason why you have sent for serum osmolality. What do you mean by that? Osmolality is the concentration of all particles in the body fluid, and one of the important substances that contribute to the osmolality of your serum is definitely sodium. So, in a true hyponatremia, so if sodium is low in serum, osmolality must be low. So, if you have hyponatremia and you see that the serum osmolality is normal or high, that means you are not dealing with a true hyponatremia. So, that is why you want to check the osmolality. Now, what do you mean? If you have hyponatremia and you find that the serum osmolality is high, that means blood is having some other osmotically active substance apart from sodium in it, which is drawing fluid inside the vessels, which is leading on to translocational hyponatremia. This happens when you are having hyperglycemia, like in DKA, or when you are administering mannitol. If a child with hyponatremia has a normal serum osmolality, this again means that there are some other substances in the blood, which is usually a hypercholesterolemia or hyperproteinemia, which can also lead on to hyponatremia, which is not true hyponatremia. Pseudo hyponatremia due to measurement error can also happen, but most of the labs now use ionic method to determine the serum sodium level, which is not influenced by this. So I hope now that is clear. So first step is to look at the serum osmolality in hyponatremia. It has to be low. If it is not low, you're dealing with some other hyponatremia. Next step is, now you have identified hyponatremia. You've identified it is true hyponatremia. Next step is to see if your child is symptomatic or asymptomatic. If the child is symptomatic, then the next step is to decide, is this be acute hyponatremia or chronic? That is, whether you're symptomatic or asymptomatic, this particular question you have to ask yourself. Is it acute or chronic? Chronic means it is more than 48 hours. That means your brain, with the help of idiogenic osmoles, have already safeguarded itself. It has already taken measures to see that the brain does not go in for a brain edema. So any hyponatremia which is more than 48 hours should be cautiously corrected. Otherwise, it leads to central pontine myelinolysis, which is a debilitating disease with permanent neurological deficit. And this is often manifest days after sodium correction. So you're not going to find features of central pontine myelinolysis while you're correcting, but you would land up seeing these features a few days after correction of sodium imbalance. So it's very important to know whether it is acute or chronic. Now you can say our child was having diarrhea, so it must be acute. Need not be. A child with a pre-existing chronic hyponatremia can have an acute destabilization also, can have a superadded reason for that. So whenever there is a doubt regarding the diagnosis, always assume it chronic and try to increase the sodium in a controlled manner only. Whereas if it is a acute hyponatremia, for example, a child with cholera, you can have dehydration with acute hyponatremia. There, increasing the sodium rapidly is not going to harm. I hope that is clear. Now coming to the next step, that is, you understood it is true hyponatremia, and you realize that anyway, whether it is acute in onset or chronic in onset, the child at present is acutely symptomatic. The child is having seizures. No doubt about it. Just go ahead and give 3% saline, 3 ml per kg over 15 minutes. You find that the seizure is not controlled, you can repeat one more 3% saline, 3 ml per kg over 15 minutes. If the seizure is still not still continuing, don't repeat the next dose. You have to measure the serum sodium and decide accordingly, while the seizure can be managed with anticonvulsants. Remember, when the child is acutely symptomatic with seizure or severe obtundation, you can aim to increase the serum sodium by a maximum of 2 milliequivalents per hour for the initial few hours. But ultimately, it should not be more than 10 milliequivalents in 24 hours. So that much part is clear. Now, when the next step is definitely to find the cause of hyponatremia. The causes of hyponatremia mainly depends upon the hydration status of the child. So remember, if your child looks euvolemic, that means this is a child. So the child may be looking euvolemic, may be looking hypervolemic, or may be looking hypovolemic. Now, if the child with hyponatremia is looking euvolemic, that basically means that the water content is in fact here normal, but water excretion is less. This is classically seen in syndrome of inappropriate ADH secretion. So here the problem for hyponatremia is decreased water excretion. So the management is water restriction. So if the patient is on full maintenance, you'll make it 2/3 maintenance. If the patient is already on 2/3 maintenance, make it 50%. So here the treatment is always you are going for a water restriction. So how do I identify if the patient is having SIAD or not? Clinically, the child will be euvolemic. The sodium will be low. The urinary sodium loss will not be, urinary sodium usually will be around 50 to 70 milliequivalents per liter. On top of that, you will find that the blood urea is very low. The uric acid is very low. Again, telling you that there is water retention. So that is how you diagnose a case of CR, and that is how you manage. Now, the next child is hyponatremia, but is looking puffy. So there is hypervolemia. Here, the cause of hyponatremia is in fact excessive water retention. In fact, sodium is also more in this child, water is also more in this child. So here the treatment is diuretics. So this you will see in CCF, in nephrotic syndrome, in cirrhosis. So here it is, the treatment is diuretics. The third is hypovolemic hyponatremia. You may see this in diarrhea. You may see this in case of polyuria, which may be secondary to Bartter syndrome, RTA, acute tubular necrosis, CAH, cerebral salt wasting. So there are so many etiologies where you can have hypovolemic hyponatremia. So in this condition, in fact, the total body sodium itself is low. And in this case, you need rehydration with isotonic fluids. So now you know that 3 different scenarios with hyponatremia, but the management is different. In CR, it is restriction of fluids. In case of hypervolemia like CCF, nephrotic syndrome, or cirrhosis, it's using a diuretic to ensure that the water goes out so that the sodium level is maintained. Whereas in case of diarrhea, vomiting, and polyuria, it is replacement with an isotonic solution. So having said that, now let us move on to the next correction, that is hypovolemic hyponatremia. That is exactly what our baby has presented with. The patient is looking dehydrated and the sodium is low. Here, if the patient is acutely symptomatic with seizure, you're going to give a 3% saline. That is a different story. If the patient is not throwing a seizure and is not acutely severely symptomatic, then what you have to do is first correct dehydration. Don't run after the sodium, because every rehydration fluid has a sodium in it. So first correct dehydration. After you have corrected dehydration, remeasure the sodium and plan the correction accordingly. So here you are planning to increase the sodium ideally by only 8 milliequivalents in 24 hours. It may go up to 10 milliequivalents in 24 hours, but preferably 8 milliequivalents in 24 hours. Which fluid will you use to rehydrate a child with hyponatremia? If it's diarrhea, you can use ringer lactate. If the patient is in shock, you can use normal saline or plasmaline. But if the patient is having failure to thrive, our 2-month-old child is only 2.5 kg. If the child is having severe malnutrition, if the child is having failure to thrive, it is always better to start your rehydration with half normal saline or half DNS. You can remeasure the sodium 2 hours later and decide whether you want to change the fluid or not. I hope that's clear. And most importantly, while you have started your rehydration, please catheterize and measure the urine output. Remember, a normal urine output in a dehydrated child is abnormal. You may be dealing with a urinary loss of sodium and water. Always send urine sodium. If urine sodium is more than 25 milliequivalents per liter, it indicates that kidney is the culprit. There is urinary loss of sodium. So what you have to understand here, that the urine sodium depends upon the serum sodium. because kidneys are responsible for maintaining the internal milieu, which means both sodium and your hydration status. So, if there is a dehydration or if there is a hyponatremia, the kidney should conserve sodium. So, in spite of having a low serum sodium, if you find a normal serum sodium in the urine that is more than 25, which basically means that sodium is getting lost in the urine. This can happen in multiple reasons. So, urine sodium more than 25 does not clinch a diagnosis. Urine sodium will be more than 25 in CR. It will be more than 25 in cerebral salt wasting. It may go up to 150 to 200 in cerebral salt wasting. In CR, it will be around 50 to 75. In ATN, it can be any amount of sodium can come through the urine that way. So you can see here, it just tells you that the loss is happening through the kidneys. It does not exactly help to pinpoint every time what exactly is the cause. Sometimes the range gives you a fair idea. As I said, in CSW, the loss is quite significant. Now, how frequently should you measure the sodium? The first sodium measurement, preferably to do after 2 hours itself, so that you know the trend, because you find that the sodium is rapidly rising, and then and there you can decrease the sodium concentration of the fluid you're using for rehydration. If you find that the sodium instead of rising continues to fall, you can use a fluid with a higher concentration. So checking the first sodium within 2 hours of rehydration is always good. After that, you need to measure 4 hourly. There are absolutely no shortcuts. You measure 4 hourly and see if the target is rising according to your plan, then modify accordingly. There is no other shortcuts happening there. Now, coming back to the child, and let us see what really happened with the child. 2-month-old, 2.5 kg child with diarrhea with an episode of seizure. So what was done? Immediately, severe dehydration correction was started with ringer lactate, 30 ml per kg over 1 hour, followed by 70 ml per kg over 5 hours, just like the guideline says. Meanwhile, the investigation showed hypoglycemia, which was corrected with B10. There was hyponatremia and hypokalemia also. And anyway, the potassium corrections were also started. Meanwhile, you can see there is some derangement of the renal function also. And because the child had shown a seizure, 3% saline, 3 ml per kg was given over 15 minutes. After that, the sodium deficit was calculated. So here the aim was to increase the sodium by 10 milliequivalents in the first 24 hours. So the calculation was 0.6 into 2.5, that is the weight of the child, into the plan of increasing 10 in 24 hours. They have taken it as 10. That means this child requires to receive 15 milliequivalents of sodium in 24 hours. Since the child was acutely symptomatic, it was decided that half of it will be given in the first 8 hours and rest half will be given in the next 16 hours. So with this plan, the treatment was started. And we should know that normal saline contains 0.15 milliequivalent per ml of sodium. 3% saline contains 0.5 milliequivalents per ml of sodium. And soda bicarb contains 1 milliequivalent per ml of sodium. So here this child requires 15 milliequivalents of sodium in 24 hours. That means the child requires 30 ml of 3% saline. Since half of it was planned for the first 8 hours, 3% saline was started at 2 ml per hour. But serum sodium, when repeated after 6 hours, it was 135. Remember, admission serum sodium was 117. Your plan was to increase to 127 in the next 24 hours. And here it is 135 in the first 6 hours itself. Where did you go wrong? You had followed the guidelines which were given. So where did we go wrong? Here the problem is you calculated the sodium deficit. The calculation was okay. You are trying to increase only by 10. You have not calculated the whole deficit. The next is you calculated the 3% saline as 2 ml per hour, and you also calculated the dehydration correction. Basically, all these are okay, but we should know that the 3% saline at 2 ml per hour, that is 12 ml in 6 hours, is going to give you 6 milliequivalents of sodium. The ringer lactate 250 ml in 6 hours is going to give you 29 milliequivalents. That means this child for whom you had initially planned to give 30 milliequivalents in 24 hours If 15 milliequivalents in 24 hours, you have landed up giving 35 milliequivalents in 6 hours. So where did we go wrong? While planning correction, always include all sodium the child is receiving. Though that is why in the beginning itself we said that whenever you come across a child with hyponatremic dehydration, please don't go for separate sodium correction unless the child is having seizures. When you do a rehydration correction, that itself is going to increase the sodium. You don't have to go and correct the deficit there, calculate the deficit. Just do the dehydration correction, check the serum sodium, and then decide what to do in the next hours. And now let us see what really happened to the child. After 6 hours, your sodium has gone up, but the child still looks dehydrated. And during the 6 hours, the child has not had a single episode of loose stools. Now, what to do next? How to proceed further? So, what has really happened here? This baby is having one episode of seizure with diarrhea, right? Child is having symptomatic hyponatremia. Initially, we thought it is acute, but look carefully. This 2-month-old child, why is the baby 2.5 kg when the birth weight was 2.8 kg? So that is significant failure to thrive. So this may be a chronic hyponatremia. And whenever you have a child with failure to thrive or severe malnutrition, always better to start rehydration with half RL with D5 or half DNS. And when catheterize, the urine output, even when the child was severely dehydrated, was 3 ml per kg per hour, which is abnormal. And once you rehydrated, the child was passing close to 10 to 15 ml per kg per hour of urine. So, how should you manage these small children who present to you with rehydration? At admission itself, take the weight of the child. If you know the insult weight, your aim is to achieve that weight. Then, if you don't know what is the well hydrated weight, you do not know, then you will clinically look at the child and continue your rehydration till the child looks euvolemic. In between, you have to measure weight periodically. In a small baby, in a young infant, weight is the best measure of rehydration. So start your rehydration in case of a polyuria with 10 to 20 ml per kg per hour. Then measure the weight. If you find there is weight gain, just continue the same rate of fluid administration. If you find that the child is having weight loss, then increase by 10 ml per kg. That means if the child is already on 20 ml per kg, make it 30 ml per kg per hour. If the child is on 10 ml per kg per hour, then you make it 20 ml. So you have to increase by 10 ml per kg. If the patient's weight is same, in spite of you giving a 20 ml per kg fluid, the weight remains same, then increase by 5 ml per kg per hour and continue till you attain either the pre-diarrheal weight or the child looks euvolemic. So this is how you manage a small baby with polyuria. Once the patient looks euvolemic, then you move to urine output plus insensible water loss. That is how you manage polyuria. Remember, just like in oliguria, you give urine output plus insensible water loss. In polyuria also, it is urine output plus insensible water loss, but this formula is applicable only after you have rehydrated the child. If you do not rehydrate and start with urine output plus insensible loss, the child will remain dehydrated. So always make dehydration correct and then move on to this. So what are the practical tips that we learned? We learned that whenever you have a child with hyponatremic dehydration or any kinds of hyponatremia, it's always better to repeat the first sodium after the first 2 hours so that you know what exactly is the trend, or you can decide whether the fluid that you have selected is appropriate or not. Always follow up the urine sodium. If you are dealing with a child with polyuria, rehydrate with the fluid which contains the same sodium as the urine sodium. That means if you are having a urine sodium more than 75, use normal saline to rehydrate. Whereas if the urine sodium is less than 75, use half normal saline to rehydrate. Again emphasizing, remeasure serum sodium minimum 4 hourly and adjust the sodium content of the fluid accordingly. There should not be a rise more than 2 milliequivalent in the first 4 hours in mildly symptomatic and not more than 4 milliequivalents in the first 4 hours in severely symptomatic. But remember, the maximum you can increase in a day is 10 milliequivalents in 24 hours. So, to conclude, what did we learn? We learned that both hyponatremia and correction of hyponatremia can be lethal. So, hyponatremia acutely symptomatic needs to be treated. Once you start treatment, it has to be a cautious treatment. We also understood that when in doubt, always assume it is chronic. Don't assume it is acute and correct it only over 24 hours. Increase should be not more than 10. In fact, 8 is preferable. The best method of monitoring for hydration status in a young infant is periodically measuring the weight and deciding the rate of fluid administration. And last but not the least, there are no shortcuts. You have to monitor sodium periodically and adjust accordingly. And also remember, in case of polyuria, it is preferable to use the rehydration fluid which contains the same sodium as the urine sodium. Thank you. I hope that gave you some insight into a bedside management of hypotension.